Alright, we're starting our final video. Thanks for staying with me. We'll do a quick radiology perspective and then review our algorithm at the end. So now let's go through some imaging. The radiology website I used for most of these slides started by differentiating Panc Cyst based on etiology. So you have your inflammatory cysts, which are the pseudocysts we just described, and then you have your neoplastic cysts. The neoplastic cysts, you differentiate between macrocystic and microcystic. The macrocystic ones are going to be your MCNs, and then the microcystic ones you differentiate based on connection to the main pancreatic duct. So again, your serous cyst adenomas are not going to be connected to the main pancreatic duct, whereas your side branch IPMNs will. So we'll go through some images and see if you can name the cyst as we go along. We'll start with a softball here, and which lesion is the pseudocyst versus which lesion is the mucinous cyst. I'll give you a second to think about it, but basically the pseudocyst is going to be the one here on the left, and it's a thin-walled unilocular cyst, whereas the mucinous cyst is going to be on the right, and it has this thick wall appearance, and that is how we're going to distinguish the two here. Now this one's a little tougher, and the question is which one is a serous cyst versus which one's a mucinous cyst. Now the way that they were described on the radiology website was this one was oligocystic versus this one was a septated cyst. So the oligocystic versus septated is hard for me to tell on here, even though on the radiology website it made it sound like it was pretty obvious. But I think when you're having a hard time distinguishing between cysts on CT scan, then an MRI can be useful, and the MRI shown here distinguishes that previous lesion that we saw on the left here. Again, here it is on CAT scan again, and then on MRI you see this central scar, which classified it as a serous cyst adenoma, whereas the lesion on the right here was depicted as a mucinous cyst adenoma. I took these next few pictures from the Blumgart HPV textbook, and we'll just look at some cysts here and some typical imaging characteristics. So this first set of images shows mucinous cyst, and you can see image A has a unilocular cyst in the tail of the pancreas. The story behind this one was that it was a young female. So again, young female with a tail pancreatic cyst that is unilocular. That is going to be a mucinous cyst. In image B, you have a patient that has a cyst with eggshell calcifications. This is also a mucinous cyst. Image C has another unilocular or oligocystic lesion in the tail of the pancreas. And then image D is also a mucinous cyst adenoma. And again, this is a large macrocystic lesion with calcifications, implying that it is a mucinous cyst neoplasm. These cysts are all going to be IPMNs on this page. So the first image A and B are both main duct IPMNs. They don't capture it entirely here, but here is one of the cysts in the head of the pancreas, and then you can see the main dilated pancreatic duct here, and then in the image B you see the same kind of main dilated pancreatic duct here. Image C, you see a branch duct IPMN. They don't show the main duct or any main duct dilation, but again, they call this a side branch IPMN. And then image D looks like a little bit more of a mess, and this was a pancreatic ductal adenocarcinoma associated with an IPMN. And the key imaging feature here that would have taken you to the operating room almost regardless of the histology is the dilated main pancreatic duct. So we've seen all these before, but again, this is from the radiology website, and we'll see what the high-risk features are as far as when they're reading out their reports. And for the pancreatic cyst, they're getting more concerned about an enhancing solid component. Again, these are solid components or mural nodules. For the main duct considerations, any duct dilation greater than 1 centimeter is a red flag for them, and then any lymphadenopathy in the area is also a red flag for a radiologist. Alright, we're in the last set of slides and we'll finish with the article that the initial algorithm I presented in the first video came from. And this was an algorithm published by surgeons from UCLA in 2016 in JAMA. So, a quick review of guidelines. We covered reinforcing that all IPMNs and mucinous-cystic neoplasms get operated on, while branch duct can be monitored if asymptomatic without main duct dilation, mural nodules, malignant cytology, or a change in caliber. Again, these have to be asymptomatic if you're going to be observing them. AGA guidelines, again, presented earlier, but we'll talk about them briefly. Their surveillance strategy for most asymptomatic, non-concerning lesions is to repeat imaging. They recommend an MRI in 1 year and then every 2 years thereafter for close surveillance. The chart also describes surveillance for patients who undergo resection or are found to have high-grade dysplasia, which includes MRI every 2 years after surgery. We've covered the imaging and patient characteristics for malignancy risk at length, but here it is again, and I would add older age to this list based on our literature review. So again, in a picture you see a typical high-risk lesion, and again the main high-risk lesions here are a large cyst with an associated main duct dilation. Low-risk malignancies, these are going to be the microcysts, okay, suggestive of a serous cystadenoma or the side branch IPMN without main duct dilation. We've talked a little bit about when to do an EUS, but basically if you have a lesion greater than 3 centimeters, you can't say for sure is a serous cystadenoma. That patient's probably going to be heading towards endoscopy. EUS is a little better than CT scan or MRI at looking for mural nodules. But again, when you're actually predicting the type of cyst, the EUS only gets you about 80% accuracy. Quick review of CA and amylase levels in each type of cyst. So again, high CA implies a mucinous lesion, and high amylase implies a connection to the main pancreatic duct. And finally, we're almost done. We're going to look at the algorithm one more time. These are the reasons to go to the OR early with these lesions, either for symptoms or cancer risk. This is the pathway that will keep you out of the operating room, either serous cystadenoma or small side branch IPMN. And this is the pathway that will take you to the operating room. This will be the last slide with the take-home points from that article. Thank you all for watching this video.